Welcome. This video presents a case of cannabis use disorder, or CU. The text was compiled by Dr. Sandy Sandbar. The video was developed by Tyler James Sandbar, BSc Computer Science, and the text was narrated by AI. First, a brief introduction. In 2019, a study of the past month substance uses among U.S. people aged 12 years or older showed that 138 million used alcohols, 58 million used tobaccos, 36 million used marijuana, and pain reliever misuse, cocaine, heroin, and others are below 2.8 millions in each category. By 2030, it is projected that the number of people who use marijuana will increase to 71 million. Cannabis use disorder, CU, has emerged as a significant public health concern, particularly in the context of increasing legalization and societal acceptance of cannabis use. Many individuals consume cannabis without developing problematic patterns, but a substantial subset experiences adverse consequences that meet the diagnostic criteria for CUD. CUD is characterized by a problematic pattern of cannabis use leading to clinically significant impairment or distress. This includes symptoms such as increased tolerance, withdrawal symptoms upon cessation, unsuccessful attempts to cut down or control use, and continued use despite social or interpersonal problems caused or exacerbated by cannabis. What is the prevalence of CUD? Studies indicate that approximately 9% of individuals who use cannabis will develop dependence. The rates are higher, about 15%, among those who begin use of cannabis during adolescence or engage in daily use. This underscores the need for effective identification and treatment strategies. Despite the growing recognition of CU, treatment options remain limited. Psychotherapeutic interventions such as cognitive behavioral therapy, CBT, motivational enhancement therapy, and contingency management, CM, have demonstrated efficacy in reducing cannabis use and promoting abstinence. Currently, however, there are no FDA-approved pharmacotherapies for CUD, although research into medications like gabapentin and N-acetylcysteine shows promise. The following is a clinical case report. The aim of the case report is to provide a detailed examination of cannabis use disorder through the lens of an individual patient's experience. By exploring the clinical presentation, diagnostic process, and treatment course, this report attempts to offer insights into the complexities of CUD and inform evidence-based approaches to management. Robert is a 45-year-old legal clerk, married with children. He saw his primary care physician because of difficulties managing his midlife issues. The physician referred Robert for a psychiatric evaluation. He went to the outpatient psychiatry clinic and expressed dissatisfaction with his stagnant career. He noted that many colleagues had advanced while he remained in the same position for 2 decades. Upon probing, Robert disclosed daily cannabis use spanning several years. He was consuming 2 to 3 joints or using a vaping pen daily. He spent approximately $70 to $100 weekly. He initiated cannabis use in college, initially in social settings, but over time, his consumption escalated to manage anxiety and insomnia. He reported strong daily urges to use cannabis, craving. He needed increased amounts to achieve desired effects, tolerance. Upon attempting cessation, he experienced vivid dreams, poor sleep, sweating, irritability, anxiety, and decreased appetite, withdrawal symptoms. His relationship with his wife was strained due to his cannabis use, leading to missed family events and responsibilities. Social impact. He denied any history of tobacco or other drug use, including synthetic cannabinoids. His alcohol consumption was minimal, limited to occasional celebratory drinks. Robert's diagnostic evaluation provides a comprehensive illustration of how clinicians apply the DSM-5 criteria to identify and assess the severity of cannabis use disorder. The severity of CUD is categorized as mild with 2 to 3 DSM-5 criteria, moderate with 4 to 5, or severe with 6 or more criteria. The DSM-5 outlines 11 criteria for substance use disorders, which are listed on the slide. The presence of at least 2 criteria within a 12-month period is indicative of a disorder. Robert consumed more than intended. He reported using cannabis in larger amounts and over a longer period than he initially intended. He made unsuccessful attempts to cut down. He tried multiple unsuccessful efforts to reduce or control his cannabis use. As to craving, Robert experienced strong desires or urges to use cannabis, particularly during periods of stress or boredom. He had social impairment. Robert was neglecting major roles. His cannabis use led to neglect of responsibilities at home and work, including missing important family events. He had interpersonal problems. He persisted on using cannabis despite recurring issues with his spouse, who expressed concerns about his absence and financial expenditures on cannabis. His social activities were reduced. He withdrew from social engagements and hobbies he once enjoyed, attributing this to his cannabis use. And he exhibited risky or hazardous use of cannabis. He continued using cannabis despite problems, even when it exacerbated his anxiety and led to episodes of paranoia. The pharmacological criteria of DSM-5 were met. He needed increasing amounts of cannabis to achieve the desired effects, indicating tolerance. And, upon cessation of cannabis, he experienced withdrawal symptoms such as irritability, sleep disturbances, decreased appetite, and vivid dreams. In total, Robert met 9 out of the 11 DSM-5 criteria for CUD, categorizing his condition as severe. So, what are the clinical implications in this patient? Robert's case underscores the importance of a thorough assessment when diagnosing SHUD. Incidentally, the same applies to other substance use disorders, such as opioids. His acknowledgement of withdrawal symptoms and the impact of cannabis on his daily functioning were pivotal in understanding the severity of his condition. This comprehensive evaluation facilitated the development of a tailored treatment plan addressing both his psychological and physiological needs. Robert's diagnostic process highlights the multifaceted nature of CUD and the necessity for clinicians to consider a broad spectrum of symptoms and behaviors. By systematically applying the DSM-5 criteria, healthcare providers can accurately identify the severity of the disorder and implement effective, individualized treatment strategies. Treating CUD should start with addressing the reasons for using cannabis, such as trauma or anxiety. This is followed by psychosocial treatment, such as cognitive behavioral therapy and motivational enhancement therapy. Then consider pharmacological drug therapy. So, what was Robert's treatment plan? Addressing his severe cannabis use disorder required a multifaceted, patient-centered approach that combined evidence-based psychotherapeutic interventions with pharmacological strategies. The treatment plan was tailored to his specific needs, considering his history, withdrawal symptoms, and personal goals for recovery. The psychiatrist offered Robert 3 psychotherapeutic interventions. 1. Cognitive behavioral therapy, CBT. CBT was initiated to help Robert identify and modify maladaptive thought patterns and behaviors associated with his cannabis use. Through CBT, he learned to recognize triggers, develop coping strategies, and enhance problem-solving skills. This therapy aimed to reduce Robert's reliance on cannabis as a coping mechanism for stress and anxiety. 2. Motivational enhancement therapy, MET. Because Robert was initially ambivalent about quitting cannabis, MET was employed to strengthen his motivation and commitment to change. This patient-centered approach facilitated discussions about the pros and cons of cannabis use, helping him resolve ambivalence and set achievable goals for abstinence. 3. The third psychotherapeutic intervention was contingency management, CM. NADCM was incorporated to reinforce positive behaviors by providing tangible rewards for meeting specific treatment goals, such as negative urine drug screens. This approach leveraged positive reinforcement to encourage sustained abstinence and engagement in treatment. What about pharmacological interventions? The FDA has no approved medications specifically for CED. However, several off-label pharmacotherapies have shown promise in managing withdrawal symptoms and supporting abstinence. 1. Gabapentin, which is prescribed at 400 milligrams 3 times daily, was selected to alleviate withdrawal symptoms, including insomnia, anxiety, and irritability. Studies have indicated the efficacy of gabapentin in reducing cannabis use and improving sleep quality during withdrawal. 2. The second off-label medication is N-acetylcysteine, NAC, which is administered at 1200 milligrams twice daily. N-acetylcysteine, NAC, was introduced to modulate glutamate levels in the brain, potentially reducing cravings and supporting abstinence. Research suggests that NAC may be particularly beneficial for individuals with HE, aiding in the maintenance of long-term recovery. 3. What about dronabinol and naltrexone, which are FDA approved? Initially, those two drugs were considered. A combination of dronabinol, which is a synthetic THC, and naltrexone, which is an opioid antagonist, were considered to address withdrawal symptoms and prevent relapse. However, due to insurance constraints and cost considerations, this regimen was not pursued. How was Robert followed up, monitoring, and supported? Regular monitoring was integral to Robert's treatment plan. Weekly therapy sessions provided ongoing support, and periodic urine drug screens offered objective measures of abstinence. These tools facilitated early identification of potential relapses and allowed for timely adjustments to the treatment strategy. So, what was Robert's outcome and adjustments? Over the course of treatment, he demonstrated significant progress. He reported improved sleep, reduced anxiety, and enhanced relationships with his family. His commitment to therapy and adherence to the pharmacological regimen contributed to sustained periods of abstinence. There were 2 instances of relapse, which were addressed promptly through therapy, focusing on identifying triggers and developing robust coping mechanisms. These episodes underscored the chronic nature of CED and the importance of resilience and adaptability in treatment planning. Some final comments. Robert's treatment journey highlights the effectiveness of an integrated approach, combining psychotherapy and pharmacotherapy in managing severe CUD. Tailoring interventions to individual needs, maintaining flexibility in treatment planning, and providing continuous support are critical components in facilitating recovery and preventing relapses. His journey through treatment for severe cannabis use disorder illustrates the complexities and potential successes in addressing this condition. His experience underscores the importance of a comprehensive, individualized approach, combining pharmacotherapy and psychotherapy.